All right, let's get right into it. Picture this. A patient needs surgery, but their heart, well, it's already failing. That's kind of like asking a marathon runner who just collapsed at the finish line to get up and sprint another mile. Today, we are walking the incredible tightrope that anesthesiologists have to navigate when they guide a patient with heart failure safely through an operation.
And that quote right there, that says it all. For these patients, there is zero safety margin, no reserve tank. The stress of surgery, the blood loss, the fluid shifts, even the anesthetic drugs themselves, can so easily push a struggling heart right over the edge. The anesthesiologist isn't just putting someone to sleep, they're managing a full-blown crisis from the very first minute.
So how in the world do they pull it off? Well, here's our roadmap. We'll start with the core problem, then we'll get into the pre-surgery detective work, cover the 5 absolute rules for the operating room, look at the specific tools they use, how they have to adapt that plan on the fly, and finally, how they navigate that super high-stakes recovery period. Okay, so first things first, let's really get a handle on the problem itself. What is actually happening inside the body when we say a heart is failing? So clinically, heart failure means the heart pump is just not enough. Think about it like a car engine that's constantly redlining, screaming at high RPMs just to idle in the driveway. It simply can't generate the power needed for the body's normal, day-to-day functions, let alone the insane demands of surgery. And what's really interesting is that heart failure isn't just one thing. On one hand, you can have systolic failure. That's a pumping problem, where the heart muscle is too weak to squeeze hard enough. But on the other hand, you can have diastolic failure, which is a filling problem. The muscle is so stiff and rigid, it can't relax to let blood in. 2 totally different issues, same dangerous outcome, and they need completely different game plans.
So, with stakes this high, how does the team even prepare? Well, long before a patient with heart failure ever sees the inside of an operating room, the anesthesiologist basically becomes a detective, piecing together every last clue to figure out just how fragile that heart really is.
And that investigation, it starts with the patient's own story. Asking things like, do you get breathless just walking to the mailbox? Or do you have to prop yourself up on 3 pillows just to breathe at night? Every single yes to these questions paints a clearer picture of a heart that's struggling to keep fluid from backing up into the lungs.
Then comes the hard data. An echocardiogram gives them a direct look, an ultrasound of the heart's pumping action. Lab work, especially potassium levels, is absolutely critical, because even a small imbalance can trigger a deadly arrhythmia. And that medication list? That tells the anesthesiologist exactly what support the heart is already getting and what drugs have to be continued right up to the minute of surgery.
So all this detective work, all these tests and questions, they all boil down to one single, crucial question. Is the patient stable? Because if their symptoms are getting worse or if they're full of fluid, a state we call decompensated, the absolute #1 safest thing to do for an elective surgery is to just hit pause. Stop, fix the underlying problem, and reschedule.
Now, once the decision is made to go ahead with the surgery, the anesthesiologist operates under a super strict set of rules. These are the core principles that are going to dictate every single decision they make inside that operating room.
And this really gets to the heart of their entire game plan. It's a framework that's often called the 5 M's.
The thing about these 5 goals is that they're all connected. You got to keep the heart rate from getting too fast, because that's just inefficient. You have to support the heart's squeeze, its contractility. You have to perfectly manage the amount of blood coming back to the heart, that's the preload, and you have to reduce the resistance the heart is pumping against, the afterload. And you have to do all of that while keeping the heart in a normal, steady rhythm. It's a constant, incredibly delicate balancing act. Okay, now we're stepping into the OR. With those 5 goals burned into their minds, it's time to pick the right tools, the specific anesthetic drugs and techniques. And here, every single choice is deliberate, and every choice is critical.
So before the patient even goes to sleep, this checklist ensures everyone is totally prepared. Vasopressors, the drugs that raise blood pressure, are drawn up and sitting there ready to go. For the sickest patients, infusions are already primed and programmed. Nothing is left to chance.
So when it's time for induction, which is just the fancy word for putting the patient to sleep, the choice of drug is everything. See, a lot of anesthetics make blood pressure plummet, which would be a disaster here. So the first choice is a drug called etomidate, and the reason is simple. It's famous for being gentle on the cardiovascular system. It gives you stability when you need it most. Now, what if regional anesthesia is an option, like numbing just the lower half of the body? Well, the technique you choose matters a lot. An epidural is almost always preferred because you can give the anesthetic slowly in tiny little doses, which lets the team carefully control the effect on blood pressure. A spinal, on the other hand, works super fast and can cause a sudden, catastrophic drop that a failing heart just can't recover from.
But here's the thing. This plan is not one size fits all. Remember how we talked about different types of heart failure? Well, the specific kind of heart muscle disease or cardiomyopathy a patient has demands a totally unique anesthetic approach.
For one very specific condition, hypertrophic cardiomyopathy, where the heart muscle is way too thick, anesthesiologists live by this powerful, incredibly memorable three-word mantra. It guides every single thing they do.
Full, tight, slow. It means you want the heart to be full of blood. You want to keep the pressure in the arteries tight. And you absolutely must keep the heart rate slow to give that stiff, thick heart muscle enough time to actually fill up with blood between beats. Get any one of those wrong and you could cause a life-threatening problem.
And this table just drives that point home. It's wild. Look at this. For a weak, dilated heart, your goal is to reduce the afterload to make pumping easier. But for a thick, hypertrophic heart, you actually want to increase it. For one, you might support the squeeze with drugs. For the other, that's literally the worst thing you could possibly do. It's a true physiological chess match.
You'd think that once the surgeon puts in that last stitch, everyone could finally breathe a sigh of relief, right? Wrong. The tightrope walk is not over. The recovery period is just as dangerous, sometimes even more so.
See, the stress of the surgery can catch up with the patient now. All those fluid shifts can overwhelm the heart and back up into the lungs. The heart might just be too exhausted to keep up a good output. This is exactly why these patients almost always go to an ICU or high-dependency unit to recover, where every heartbeat and every single breath is watched like a hawk.
So, when you really step back and look at the whole picture, you see that this entire journey, from that first clinic visit all the way to discharge from the ICU, is one continuous high-wire act. It's just an incredible testament to foresight, meticulous planning, and constant second-by-second vigilance.
You know, taking a deep dive into just this one specific challenge in anesthesia, it opens up a whole universe of complexity and precision that's happening every single day in medicine, usually completely out of sight. It really makes you wonder, what other incredible balancing acts are being performed just beneath the surface?